Welcome everyone. I would like to present my PhD topic, which is optimizing the nutrition of critically ill children by timing and dosing. My name is Andrea Lábodi, and I am a pediatrician in Bács-Kiskun County Hospital in Kecskemét, and also a PhD student in Semmelweis University. As a pediatrician, I started to interested in intensive care. This is how my vision started, which is provide adequate nutrition for critically ill children to improve their survival. And my mission, which is investigate the optimal nutritional therapy for critically ill children for better outcome. I have two specific goals related to this mission. The first is about the optimal protein intake, and the second is about the optimal timing of parenteral nutrition. My first project is investigating the effect of higher levels of protein intake on mortality and recovery of critically ill children. In the intensive care, the nutrition therapy is very important, a crucial part of the management of the critically ill children, and the protein is one of the most important substrates. The inadequate protein intake can increase mortality and prolong in-hospital days, and now the recommended minimum protein intake is 1.5 grams per kilogram per day to avoid a cumulative protein deficit, but the optimal intake is likely to be higher. So our aim is to determine the optimal protein intake for critically ill children. So our clinical question is, what is the optimal dose of protein intake to reduce mortality and morbidity in critically ill children? We use the PICO framework, the population children in the pediatric intensive care unit, the intervention and comparator, the different levels of protein intake. Our first outcomes are clinically outcomes, mortality, length of stay in the pediatric intensive care unit, and mechanical ventilation time, and secondary are nutritional outcomes. Our hypothesis is 2 to 4 grams per kilogram per day protein intake provides the best survival and shorter stay in the pediatric intensive care unit. And the clinical implication is accelerate recovery through optimized nutrition. Here is my search key. The first domain is about the pediatric population, the second about the critical illness, and the third about the protein. We ended up more than 9,000 hits, and after the selection, we had 45 eligible articles, and with the citation chaser, 4 more articles. Here is my progress. We almost finished all the analysis. The statisticians are working one outcome. I started the manuscript writing just in the days. I would like to show my first result. It's mortality, which is the hardest outcome in intensive care. It's between 8 to 10% in high-income countries. And here we included 4 articles. All of them were RCTs with more than 300 patients. The heterogeneity was moderate. It's because the different diseases and the different age groups. And we compared less and more than 2 grams per kilogram per day protein intake. As you can see, we used risk ratio, and the risk ratio was 0.66, which means that in the higher protein intake group, the mortality was decreased with more than 30%. It's not statistically significant result. However, in all of the studies, the high protein intake was the beneficial. So we think it's because of the low event number, and with more studies, it can become statistically significant in the future. And next is the mechanical ventilation time, which also a very important outcome in intensive care, because longer mechanical ventilation can increase the risk of adverse events, nosocomial infection, and other problems. And it's usually between 3 to 8 days, but it depends on the disease. Here it was measured in hours. We included 5 articles. All of them were RCTs with almost 300 patients. And we again compared less and more than 2 grams per kilogram per day protein intake. The heterogeneity was moderate again with the same reason. And we used mean difference, and the mean difference was minus 21.8, which means that in the intervention group, the mechanical ventilation time was shorter, almost 1 day, which is clinically, again, very relevant. However, it wasn't statistically significant. But almost one study, all of them, in all of the other studies, the intervention group was the better. And that one study, however, it was an RCT, the severity score was higher in the intervention group. So we think it's the reason. We have some strengths and limitations. We included RCTs with objectively measurable and hard endpoints. The limitations are the heterogeneous population, the low number of patients, and the lack of statistical significance. And I would like to speak about my second project, which is investigating the optimal timing of parenteral nutrition on mortality and recovery of critically ill children, and it's a randomized controlled trial. As I mentioned, the nutrition therapy is a very important part of the management of critically ill children, and the early enteral nutrition is a preferred choice. But not all patients can receive enteral nutrition, and in this case, the parenteral nutrition is needed. But the optimal timing and dosing of parenteral nutrition is unknown, and it's related to the phases of the critical illness. The first is the acute phase, and in the acute phase, we can speak about early and late acute phase, and after that, a post-acute or a stable phase. Usually, the early phase is the first 4 days. After 4 to 7 days is the late acute phase, and after the stable phase. And different nutritional strategies are needed in every phase. Recent guidelines suggest that we should delay the parenteral lipid and protein intake until 1 week. But it's based on one single RCT. We only and the study only compared day 1 and day 7. And there is a smaller but contradictory study. So there is not enough evidence on the benefits of starting parenteral nutrition earlier or later. Our aim is to determine the timing of parenteral nutrition for critically ill children. So our clinical question is, does starting parenteral nutrition on day 4, which is late acute phase, change mortality and recovery in critically ill children? The population, again, children in the pediatric intensive care unit, but now with inadequate enteral nutrition. The intervention starting parenteral nutrition on day 4, which is the late acute phase. The comparator, the starting parenteral nutrition on day 7, which is the stable phase. Our first outcome is length of stay in the pediatric intensive care unit. Secondary, the mortality days on mechanical ventilation and the in-hospital days. Our hypothesis is starting parenteral nutrition on day 4 is clinically superior to withhold it for 1 week. And the clinical implication is accelerate recovery through optimal nutrition. We worked on the protocol drafting, the inclusion-exclusion criteria, the intervention and the outcomes, and hopefully soon we can move to the study protocol writing. Summary, I have 2 ongoing projects. The first about the optimal protein intake. I would like to finish it this year autumn. And the next is the optimal timing of parenteral nutrition, and I would like to finish it next year autumn. And I would like to finish with a quote from Albert Einstein: the important thing is not to stop questioning. Curiosity has its own reason for existing. Thank you for your attention.
I would like to ask, is it the same dose of nutrition for the children between all ages? I mean, how did you define children? Is it the same as it for 18 years old or for 6 years old? Can you elaborate on that, please?
Yes, it's very hard. And now the recommendation is for all the children. And we wanted to do subgroup analysis based on age, but we don't have enough articles. But in the mortality, all of the articles which included just have children in the neonatal and toddler age. So it's
more specific.
Yes.
Did you include all ICU patients, or were there any exclusion criteria?
Yes, we had some exclusion criteria. For example, inborn metabolic diseases and dialysis. Yes, these were the exclusion criteria.
Thank you.
I was wondering, based on your results, would you recommend giving patients more than 2 grams per kilograms per day of proteins? I mean, the data shows that it might be beneficial, but still we don't have a statistical significance.
My opinion that it's better for this age group, as I mentioned earlier, the toddlers and the neonatal age, but I can recommend that we need more RCTs with different age groups.
One of my questions would be related to the previous question. I would like to ask, based on your experience, you mentioned you are working in the ICU, which amount is ideal? What is the 2 grams, or because
I think it's between 2 to 3 grams. Maybe more than 3 grams can be adverse events, but I think the optimal is between 2 to 3 grams.
Okay, thank you. And I have another question regarding your second project. You mentioned in the outcomes for the first outcome, length of PICU stay. Why did you choose in your second project for the first outcome?
Yes, so we discussed it a lot because first, of course, we wanted mortality, but fortunately it's a rare event, so we need lots of patients for mortality. So we choose another relatively objective endpoint, which can be the ICU stay, because we can make rules for it, and that's the reason.
I think safety is very important when you use protein intake, so especially for the kidneys, because high amount of protein can be harmful for the kidneys. What are your thoughts regarding this?
Yes, this was the reason I mentioned that I think it's between 2 to 3 grams, which is the optimal, not higher. Unfortunately, in the articles, they didn't have too much data about the safety. So some of them have results on the gastrointestinal adverse events. Some of them, the laboratory results, for example, creatinine and other kidney function results, but not the same in the articles, so we can't analyze them.
My question would be that, as far as I understood, in your second project, you hypothesized that the best timing of starting the parenteral nutrition depends on if the patient is in the late acute phase or in the stable phase, and you mentioned day 4 and 7, but I guess it's not always day 4 and 7. So are there some other markers which can actually separate these phases, which you could time the starting of nutrition to? It's
not. We don't have a very specific definition for this, or laboratory results or something like this, but usually for the day 4 they start to become stabilized, and the very big cytokine storm can decrease, so this is why we chose the day 4.